Okay, got it. Hi, everyone. Good afternoon. My name is Dr. Nicole Parellada. I am one of the chief medical residents for the internal medicine residency program. It's my pleasure today to introduce to our grand rounds, Dr. Franco de Alessio. Dr. de Alessio earned his MD from Universidad Peruana Cayetano Heredia in the year 2000. He completed his internal medicine residency at Johns Hopkins in 2004. He performed a fellowship at the Institute of Tropical Medicine, Alexander von Humboldt, and then went on to complete fellowship in pulmonary and critical care medicine at Johns Hopkins in 2008. He is currently assistant professor within the Division of Pulmonary and Critical Care Medicine at Johns Hopkins University School of Medicine in Baltimore, Maryland. Dr. de Alessio identifies himself as a physician researcher, directing his translational focus in identifying changes in the immune cell landscape in pulmonary and critical care pathologies. His research interests center on the immunological determinants of acute lung inflammation and repair, particularly age-dependent lung immune response in patients with acute lung injury and ARDS, regulatory T cells in lung injury and repair, and modulation of alveolar macrophages, innate immune response in ARDS. Arduous work has led him and his team to find endogenous therapeutics that promote Tregs and reprogrammed activated macrophages by DNA methylating agents and IL-4 therapies, respectively. They have made significant contributions to understanding the field of lung repair and hope to translate therapies to patients suffering from acute respiratory distress syndrome. Dr. de Alessio is a permanent member of the Lung Injury Repair and Remodeling Study section for the NIH's National Heart, Lung, and Blood Institute and a current peer reviewer for several journals, including the American Medical Journal of Respiratory Cell and Molecular Biology, the Journal of Immunology, the Journal of Critical Care, and the Journal of Clinical Investigations, to name a few. Once again, please join me in extending a warm welcome to Dr. Franco de Alessio to our medical grand rounds.
Well, thank you very much for the kind introduction. Good afternoon. It is a pleasure, and I'm very honored to have been invited here. Dr. Weiss, Dr. Punjabi, thank you for having me here. I am delighted and excited to soon be joining the University of Miami family. Today, I'm going to talk. Thank you. I am borderline obsessed with lung repair, resolution of inflammation. My primary objective for this talk is to inspire young minds to join a career in science, which is incredibly gratifying. That is my major objective. My second objective is to discuss some things we can do to our patients in the ICU to promote lung repair. And then I'm going to tell you a little bit about what we have found on the bench and how that made it all the way to humans with acute respiratory distress syndrome. These are my disclosures. I have funding from the NIH. We partner with Celencos, which is a Houston company that funded our trial that I'll talk to you about. And we do have a patent on methods and compositions to accelerate resolution of acute lung inflammation, although there is no financial disclosures for this. So we need to start. This is the outline for my talk. We're gonna talk about the definition of ARDS that has seen an evolution, mention some of the importance of lung protective ventilation, some adjunctive therapies, the story in the bench that made it all the way to the first in human novel therapies for the ARDS. This is a common scenario. This is, of course, I don't need to tell this audience, a normal-looking chest X-ray and a young patient that developed a viral pneumonia and ultimately went into acute respiratory distress syndrome. This is a syndrome that is characterized by acute hypoxemic respiratory failure. There is a precipitating event, and it leads to two cardinal features. There is exuberant and dysregulated inflammation in the lungs, and the alveolar capillary membrane gets leaky. The lungs get flooded with protein-rich fluid, and immune cells, coagulation cascade turns on. And this is a syndrome that leads, unfortunately, to a very high morbidity and mortality. This patient, despite maximal therapy, did not survive day 6 of her ICU stay. So these are data from a New England journal by Rubenfeld. There's a pre-COVID, there was an estimate of 200,000 cases of ARDS with a mortality of about 40%. So just to put it in perspective, this is the same mortality that combined breast and prostate cancer cause. Clearly, this paper did not predict the pandemic. There is projections that the incidence and prevalence of ARDS will increase. We have seen that with 3.4 million deaths across the world, and most of this from COVID, and most of these cases were due to acute respiratory failure. These are some of the common causes of ARDS, the leading one being pneumonia, followed by sepsis, aspiration, and other ones. Not only this causes tremendous morbidity and mortality, but the healthcare utilization is tremendous. ARDS affects around 10% of total ICU admissions, up to 20% if you're receiving mechanical ventilation. The mortality is unacceptably high, and we can do better. There's also a problem with recognition. Up to 50% of cases are not identified as acute respiratory distress syndrome, so hence we cannot provide the optimal standard of care treatment. This happens mostly when the cases are mild and it doesn't get labeled as ARDS. And even when the cases are severe, you can misdiagnose up to 20%. It is well known the long-term consequences of ARDS. We are seeing outpatients that survive ICU, and this is what we term post-intensive care syndrome. And this is a real problem, especially after COVID pandemic. And this takes multiple phenotypes that we need to recognize too. This mentioned the pandemic and how ARDS became a topic of great interest in the critical care community and around the world. So we need to start by the definition. So if we cannot recognize the problem, we won't be able to treat it. And the definition has evolved over time. A group of young faculty in Denver published a landmark Lancet paper in 1967 describing 12 patients with refractory hypoxemia bilateral infiltrates that would perhaps suggested response to positive pressure and PEEP, or positive end expiratory pressure, and perhaps a role for steroids. Certainly luminaries. I would say that this syndrome was known as war lung. Combatants in the field will have trauma, blast trauma, and they will develop hypoxemia respiratory failure. And it was just not known that it was called ARDS. But this was first put on the map in '67. When I trained as a fellow and as a resident, we used to use the American European consensus where we had certain criteria, the acute onset, although I would mention that there's no specificity on the time, so this was vague. There was a oxygen over FiO2 ratio of less than 300, a term called acute lung injury. That term has fallen off favor, but we still use it in the bench. Bench scientists that study ARDS often name acute lung injury, but that term has fallen out of favor. And I should point out that there's a criteria of wedge pressures. I think if you walked in an ICU 30, 40 years ago, there was a large number of patients with Swan-Ganz catheters, and that practice has certainly fallen out of favor. So the definition needed to evolve. The Berlin definition that you're probably aware came up. That just meant they met in Berlin. Experts met and came up with a definition. It then got modified, and then recently a article published by Michael Mathey, who is one of the leading experts in ARDS in the world, had a consensus paper showing can we do better to identify this syndrome, to standardize the definition, to pick up the syndrome much earlier. And I'll mention this a little bit about this. So critical care is changing. And critical care is not just for developing countries. Certainly, There are logistical challenges that have led to expand this definition. And so here we have a intubated patient. The definition here is much more in line with the conceptual framework of Berlin definition, where you have a PaO2 or FiO2 ratio. You have somebody receiving positive and expiratory pressure, and they have bilateral infiltrates. And so this is fairly straightforward. But what about with the pandemic, we would see wards full of patients on high flow nasal cannula. So some experts said, well, we're not capturing these patients, all right? They're not on positive pressure, although you would argue that the high flow delivers some PEEP. And so high flow nasal cannula has made it now to the definition of ARDS. How about in resource limiting settings? Well, I come from a country where certain towns don't have mechanical ventilation, don't have high flow nasal cannula. And so you can provide supplemental oxygen by a Venturi mask. So I think the experts sort of suggested, well, we should be capturing those patients. And so the definition of positive end expiratory pressure and arterial blood gases also were expanded to say most patients have a peripheral SAT. Can I use that as a ratio and actually make the definition meet criteria? And so this has been validated in multiple studies, and you can now use the SAT, the pulse oximeter. So in summary, this is the global definition that is being embraced by the community. There's, of course, some challenges. The timing is now more refined to within a week. I would say most ARDS patients will develop after a precipitating factor within 72 hours. So for example, if I aspirate or if I get a blood transfusion, unlikely that I'm going to develop ARDS 7 days later. Is that right? I'm going to develop it within the next 48 hours, 72 hours. Now, the only exception here would be COVID. It is known that COVID infection, most patients that go into develop ARDS is usually 7 to 10 days. Of course, the origin has not to be related most to hydrostatic pulmonary edema. Now, patients with heart failure can develop ARDS, but the precipitating factor has to be identified. All right, patients with chronic lung disease can develop ARDS. Again, the precipitating factor will be more related to the ARDS than the underlying disease. The chest imaging is now expanded to include CAT scans, also ultrasound. So POCUS or ultrasound in the ICU has become a widespread use. I would argue that POCUS should be part of your physical exam. And then complements and strengthens your physical exam. But we should all, I am not formally trained in ultrasound. I regret that. I am trying to get better, but I would argue our young generation should be trained in POCUS and should become the standard of care, especially in the ICU. Here, the oxygenation, I mentioned to you, we now use the peripheral SAT over FiO2 instead of that 300 range. It's 350, assuming your SATs are below 97. And the use of high flow nasal cannula has made it to the definition as long as you're getting more than 30 liters. As a general rule, for every 10 liters of high flow, you get about 1 of PEEP, give or take. So these patients are getting at least 3 of PEEP under definition. And if you're in a resource limited setting, then these criteria are waived, realizing the logistical challenges for some of these settings. Now, how about lung protective ventilation? Now we've identified how to define ARDS. Once you have ARDS, how I'm going to treat the patients. Mechanical ventilation, clearly lots of benefits. You secure the airway, you protect the airway, you support gas exchange, you let that treat the underlying cause, you let the lung heal. But I would argue that we need to start thinking that mechanical ventilation can cause a great deal of damage if we don't use settings that are protective. And that's really important. I'll give you an example. These are rat lungs. The one right here on the left is a normal appearing lung. We submit those lungs to high pressures from mechanical ventilation. No other insult. This is 20 minutes where you can see some petechia already forming. This is 4 hours after non-protective lung ventilation, where the lung becomes absolutely almost look like a liver. flooded with fluid and blood, and just from using deleterious settings. Well, those are animals. How about humans? Let me provide you an example. This is a case of an ARDS patient. You can see consolidated areas of the lung, and the same patient got a PET scan. And interesting, the areas that are least compromised, the areas that are probably getting over-distended from the ventilation provided by mechanical ventilation are the ones lighting up from PET scan. And these are all coming from immune cells, inflammatory cells, underscoring the importance that this occurs in humans too. So the concept of lung protective ventilation is critical. This is not just macroscopic where I get atelic trauma, volutrauma, barotrauma. I think we need to start thinking about biotrauma. It is very clear that if I don't provide lung protective ventilation, I am going to cause tremendous spillage of cytokines, chemokines that are going to ultimately affect other organs, kidneys, DIC, encephalopathy. And so this is something that is paramount. You are providing lung protective ventilation not to support the lungs, you're providing it to support other organs. Most patients with ARDS, if they survive the first 3 or 4 days, they're not dying from respiratory failure, they're dying from multi-organ failure. And so having that protective ventilation will help not just the lungs, but other organs. So this is, I think, very critical. So this led to one of the most quoted randomized controlled trials led by the ARDS network. One of my ICU mentors, Roy Brower, led this trial where they basically said, well, we're going to test this out, okay? We're going to basically provide, because it's very easy to say, well, patients with ARDS have atelectasis, consolidations. Well, I can give them very generous tidal volumes and open up those lungs. My ABG will get better, no question. But ultimately, those patients have an incredibly high mortality. So this was randomized, 2 groups, low tidal volume versus high or normal tidal volume at that time. And at the end of the trial, the lung protective ventilation has multiple ingredients. You target a tidal volume that is based on predicted body weight. Predicted body weight is determined by height and sex, biological sex, no weight. So we target ranges from 4 to 6. We measure mechanics on the ventilator, plateau pressures. We try to target them below 30. Permissive hypercapnia is a concept that's very important. So what I do is if I drop your tidal volume, my carbon dioxide will rise. What's the problem with that? None. We do not need to normalize an ABG on a patient with ARDS. We can let permissive hypercapnia ensue. There's probably only 2 exceptions. If your right ventricle has a poor function and if you have increased intracranial pressures. Those 2 organs, right ventricle and brain, don't like high CO2s. If you don't have any of those 2, incredibly well tolerated. We drop the pH to 7.2, no problem. RT comes back, the nurse says, hey, do you have a problem with ABG? No, we're a target. Perfect, we're protecting those lungs. We've gone as low as 7.1, 7.15. We have some targets with oxygen. Oxygen is also a double-edged sword. Too much oxygen, bad. ROS, lack of healing, worsening injury. So then we provide a PEEP FiO2 table to try to minimize the oxygen toxicity. And then today, I'm not going to talk about driving pressures. Is a personalized way to set up your PEEP. This was the results. First time ever that the community lower mortality by just providing lung protective ventilation and a relative reduction of 30% in mortality, 40 versus 30. So lung protective ventilation creates some challenges. You have a very dyspneic patient that wants to take big breaths. And so if your patient is going to be desynchronous with the vent, you're going to have to sedate your patient. The timing of that is very important, all right? So if you're early on your disease, just sedate your patient, protect those lungs. Once they get better, you can maybe liberalize that or you can lighten up the sedation. But I think ultimately this is not just the lungs, it's the biotrauma that I mentioned recently. How about lung protective ventilation for all? I might be, some of you might say, well, I don't treat ARDS, all right? I don't really encounter those patients, but I would argue that there is actually good data to provide lung protective ventilation, even if you don't have ARDS. The pulmonary complications, the length of stay, the utilization of healthcare is all improved by using lung protective ventilation, even if you don't have ARDS. This is also applies to surgical patients, it applies to cardiac patients. And so I would argue that unless you're having acute increases on your intracranial pressure, that most patients we should be providing lung protective ventilation as a standard of care. How about other therapies? What other tricks we have to support our ICU patients? Proning. So proning has received a lot of attention recently, especially during the COVID-19 pandemic. You basically put the patients in their tummy, and that offers a reduction in gravitational effects of the pleural space. You offload the heart and the abdomen from the posterior parts of the lungs, and you allow a better shape matching of the lungs, and allow the distribution of the tidal volume to much more uniform and improve VQ mismatch. It's fascinating. With proning, you improve oxygenation, but actually patients that don't improve oxygenation still get benefit, suggesting this is a mode to protect the lungs. It's not just a mode to improve oxygenation. This was also a positive randomized controlled trial. There are not that many in critical care, so we cherish them very much. So lung protective ventilation is one, and prone, this is the Perceiva trial, randomized patients to supination and prone. This was done in severe to moderate cases, and it was done early, and it was done for prolonged periods of time. We're talking about 16 hours at a time. With COVID, I think we were in uncharted territories. We had patients that we were proning for 3, 4, 5 days, almost like, I mean, that's the only way we can oxygenate them. So I think more to be understood, but this is a positive trial that led to actually reduction in mortality in the prone arm. How about patients that I do maximal therapy? I prone them, I paralyze them, even throw some inhaled nitric oxide, do maximal therapy, and I cannot oxygenate them, or their pressures are so high that I can't do anything for my patient. Well, extracorporeal life support is an option. I was not a believer, but extracorporeal life support with COVID and then also with young people with single organ damage, I think should be considered. I think we should try to do maximum medical therapy, and if we have those challenges, consider it. You're taking the blood away from the venous circulation, you're oxygenating, you're putting it back. The beauty is that you are allowed to dial down the respirator and basically provide extreme lung protective ventilation. I think that's probably where ECMO shines. So this was also a randomized controlled trial. It's called the EOLI trial that used multi-center and had 2 very sick people groups, the control arm and the ECMO arm. I should mention these were centers that were keen and very used to do ECMO. So it's very hard when you don't do this all the time and you want to do it. So I think if you have a lot of experience, of course, your rates of complication are significantly improved. And it led to an 11% absolute reduction. And this was published in New England, and you look at the p-value of 0.08. And this, if you read the abstract, you read the conclusion, it's a negative trial. Well, we need to look a little deeper. There's a Jeff Drazen editorial even suggesting that there might be some role. And looking in between the lines, you look at the crossover rate of those patients. The patients on the control arm, 28% were so sick that they had to cross over to the ECMO trial. And I think that probably killed the trial, meaning the statistical significance, but I would argue that there is potentially a role for this. And then if you look at post-patient analysis of this trial, there was an absolute reduction in mortality in these patients that were randomized to ECMO. And so I think it's part of our armamentarium. So in summary, these are some of the management we can do. Lung protective ventilation, I think there is no reason that should be standard of care. It leads to reduction in mortality. It leads to reduction in ventilation-free days. This should be standard of care. If you're very sick and severe to moderate ARDS, your PaO2, FiO2 ratio is less than 150, we should be proning those patients more often. ECMO, I think based on the trial, equipoise, but I think in the certain selected patients that we can treat medically, they should be considered for ECMO. Equipoise on paralysis, equipoise on steroids. There's some positive trials on steroids, some trials that were not positive. I think they might have a role. I think we're starting to phenotype our patients better. There is a hyperinflammatory phenotype and there's a hypoinflammatory phenotype, and perhaps those patients will respond different to therapy. So I think it's more to know, more to follow. There is no benefit or no harm to using inhaled nitric oxide. Inhaled nitric oxide buys you time, but it really doesn't improve outcomes in our patients. Recruitment maneuvers should be discouraged. They actually have potential harm. Another modes of ventilation have not shown a benefit like the oscillator or APRV. Although there might be some role to use it as rescue before sending somebody to ECMO, at least to try some settings on APRV very briefly. We can do much better. A third of our patients are getting tidal volumes 8 or higher. That's unacceptable. That's not standard of care. If you look at the 4 to 6, the minority of patients are getting true protective ventilation. We can do much better. This changes mortality. The same for other interventions like proning. We're proning 60% of our patients. I think COVID was an exception. I think that we saw much more proning incidents, but if your patient is severe, we should be using proning. This is a relatively cheap, and if we have experience with our nurses and RTs, we can achieve this very easily. So I mentioned to you 30–40% mortality. That's not good. We have to do more, and this is what trigger our most of our ATP gets chewed up, thinking of what can we do to impact this disease. So most of the field has focus here. Your normal lung, your injured lung. I am able to model this in an animal. I'm able to block my favorite protein, my favorite cytokine, my favorite pathway, my favorite gene, and I can cure an animal if I intervene early. If I pre-treat the animal. Success. You go to a clinical trial, fails. So we said, well, let's take a step back. Most of our patients are presenting with injury. They come with ARDS. They come inflamed. The early inflammation has way set in. Can we study mechanisms related to resolution of inflammation of lung repair? And that's what we ask. What are those mechanisms? What leads to resolution or healing of that lung? So we use simple animal models of ARDS. I am going to disclose an animal is not a human. The ARDS in humans is much more complex, but I would argue that the animal offers an important reproducible model where we can study pathways, where we can study therapeutics. So we intubate our animals with little angiocalves. We instill an insult either with lipopolysaccharide. Most commonly, we use live bacteria, and then we study responses over time. And this is a summary of lung H&E sections where you can see a normal appearing lung. There's early inflammation that peaks around day 4. This is where most of the animals either survive or die. And then if you wait long enough, 17 days, that lung recovers. So we did very simple, and this is a very simple, not hardcore science. We said, let's just look at the profile. We look at a simple cytospin on the BAL at different time points. No neutrophils at baseline. You have influx of neutrophils earlier on day 1, day 4. By day 10, those neutrophils are gone. That's a cornerstone step for resolution of inflammation. But we noted this. What is this? Lymphocytes are showing up right here at later stages. Right here, this little guy right here, simple cytospin. And we ask the question, what are those cells doing? Are they bystanders? Or are they playing an active role in repair? And so that's what we set to do. We took advantage of some of the transgenic animals. We have animals that they lack an enzyme critical for development of T and B cells. These animals are indistinguishable. You look at them, they look identical to their wild-type counterparts. They just don't have any lymphocytes. So we challenged into our model. We gave them LPS or pneumonia. Their early injury was identical. We couldn't tell a difference. Waited long enough, the wild type animals with lymphocytes recovered. The lymphocyte deficient animals had unremitting lung inflammation. We said to do adopted transfer of immune cells. And we did all these fancy transfusions of specific immune cells, and we saw the response segregated to a specific subtype of a CD4 T lymphocyte named regulatory T cells, or known also as Tregs. They happen to be one of my favorite cells, and I'm trying to understand more about them in the context of lung repair. And so we tell you a little bit about Tregs. They come in multiple flavors, but the one that is most studied is the one that is thymic derived. They express CD25, which is the interleukin-2 receptor, and they have the transcription factor FOXP3. They are critical in autoimmune disease, allergies, tolerance, and they're considered part of a cornerstone step for immune tolerance. And they can certainly be involved in dampening or putting brakes on excessive exuberant inflammation or immune responses. So we took advantage of some other animals where we can basically have an animal that has the diphtheria toxin knocked in their FOXP3 promoter. If I give those animals diphtheria toxin, I can selectively deplete their Tregs acutely. And so I did that with some pneumococcal pneumonia, which is a common cause of pneumonia and ARDS in humans. And you can see the mortality was increased, their lung injury markers were increased. And in the absence of Tregs, that lung does not repair and that lung is persistently injured. And we have done this with multiple models. Mechanisms, I will summarize this over the work that we've done for multiple years. How come a cell, a Treg, if you count the cells in the lung, a Treg represents less than 0.1% of the cells in the lung? Why are they mediating this miraculously effect? They cannot be doing it on their own, is that right? And so we postulated they might be doing it through orchestrating repair by cross-talking with other cells. Macrophages are a big one. They modulate macrophage responses. Dr. Garibaldi in our labs show that they are participating in fibroproliferation. They dampen the fibrocyte recruitment into the lung. The fibrocytes deposit collagen in a CXCL12 manner. Jason Mock, who now leads a successful lab in North Carolina, show that these cells interact with type 2 cells. They actually repair the enhanced proliferation of type 2 cells, which are important to repopulate that epithelium in the lung. And we are working on trying to see how they affect the endothelium and muscle repair that other groups have shown too. Human relevance. This is all mouse stuff. They're important in humans. We describe the presence of Tregs in humans with ARDS. Jason Mock was able to show that the number of Tregs correlated with the ability to recover or get extubated after you have ARDS. And Ben Singer in Northwestern has shown that these cells are present in critically ill patients with pneumonia, and they have a unique transcriptional profile that they can assess by single-cell RNA-seq. The COVID-19 pandemic hit. We were desperate. This was pre-steroids, all the biologicals that we sometimes have some minimal effect on COVID ARDS outcomes. There were reports that Tregs were defective in numbers. And so this company, Selencos, reached out to us and say, are you interested in running a trial? They coincidentally didn't know I studied Tregs for a good part of a decade. And when they reached out to me, I said, yes, let's do it. I think we should try this. I think there has biological plausibility. And at that moment, there was nothing we can offer our patients. So this company has done trials on cord blood Tregs in different diseases, but not in acute inflammatory diseases, more chronic diseases. Why cord blood? Cord blood Tregs and human adult Tregs are a little bit different. Cord blood Tregs are more naive. They have a different TCR repertoire. And they also are more committed to their lineage. They usually don't turn pathogenic T cells like adult Tregs can. They have receptors that are home to the lung. They can suppress immune responses in vitro. And when they get stimulated under inflammatory conditions, they don't turn into pathogenic Th17 cells that can promote further inflammation. We can show that this cell hones in into the lungs when adoptively transferred in mice. And we can show that they can participate actually in repair of some experimental models of injury. So this led us to encounter at the beginning of the pandemic, we had a couple of very sick patients that were dying. They were maximum medical therapy. One was receiving extracorporeal life support. And we got an FDA IND for compassionate use of Tregs. And this is be myself in the ICU with the first patient. We infused regulatory T cells. These two patients recovered. They made it out of the ICU. Again, anecdotal medicine, but at least gives us, and it was safe to deliver them. These patients were on multi-organ failure, ARDS, severe ARDS, AKI, 2 pressors, and they made it. And so that encouraged us to catapult our randomized control trial that I'll tell you about. So we run a multi-center trial, a phase 1 double-blind placebo-controlled safety and early efficacy of cord blood Tregs in severe COVID ARDS. So patients had to be intubated. So we really selected, almost in retrospect, maybe we should have selected not a sick patients, but these patients were all intubated. They had to have moderate to severe ARDS, and they had to be within 5 days of their initiation of mechanical ventilation to randomize. There were 3 arms: placebo, a low dose $100 million infusion of Tregs, and a higher dose of Tregs. And the Tregs were given on day 0, +3, and +7 of randomization. Our initial thought was, well, let's do a safety trial. Phase 1 trials are usually safety. The FDA said, no, you have to include some early efficacy. Otherwise, we won't give you permission. So we had to include overall survival at 28 days as a primary outcome. And of course, we had some other secondary outcomes. I'm a little proud that we actually gave it a nice name, RESOLVE trial. All these cardiology trials have fancy names, and I was a bit jealous, so we gave it a name. And so the inclusion criteria are, I mentioned, the severe ARDS. You have to be an adult. You have to be within 5 days. You have to have COVID, of course, confirmed. Some exclusion criteria where we didn't expect you to survive within the next 48 hours, if you were getting other immunosuppressants, and so on. These are some of the summary of the baseline characteristics. The randomization was not as good as we thought. The placebo and the low-dose Tregs were very similar, except that the low-dose Tregs had a much higher incidence of vasopressor requirements. Unfortunately, our high-dose Tregs had a much higher BMI. They were much sicker. Their PaO2-FiO2 ratio was lower. They also had more encephalopathy. Their C-reactive protein was higher. Not surprising, their IL-6 level, which is one of the major triggers or drivers of IL-6, was higher. So that was unfortunate, but that's nothing we could have done at that moment. Of course, this was blinded. All 3 groups received standard of care. This was later during the pandemic, where dexamethasone and remdesivir became the standard of care, and so most patients were receiving that. And we use this balanced randomization used Bayesian regression analysis, where the number, I mean, this was a small trial, right? This was really, it was hard to pull, but we enrolled all our patients, and with Bayesian analysis, we showed that the probability of beneficial effect of the low dose Tregs was 98% compared to placebo. These are some of the survival intention to treat probabilities. In black is the placebo, the low dose Tregs, and unfortunately the high dose Tregs, the mortality was higher. And I mentioned that group was significantly sicker at randomization. So our primary endpoint, it was safe. It was safe to transfuse these Tregs in humans that are incredibly sick on pressors, with severe inflamed lungs, and that there is perhaps a signal of beneficial effects when you receive the low-dose Treg infusions. It is very clear that we need to do more and larger confirmatory studies. This just basically gives us a green light to do a bigger study. I can't say this is, and we should be giving Tregs to everybody with ARDS, but it's certainly encouraging. But one thing I should mention is that we looked at the patients that received early treatment within 40 hours of the intubation had the most benefit in survival, almost suggesting and underscoring that perhaps we need to target this disease a little bit earlier, not when they're intubated on pressors, that perhaps when they're receiving high flow nasal cannula. And so certainly that will be a consideration for future trials. Some future directions is, can we take, because this, we're talking about allogeneic Tregs, off the shelf, cryopreserved, ready to use. Is it possible that I take your endogenous Tregs, put them in a dish, culture them with an optimal media, and create a super Tregs akin to what we do with CAR T cells for certain cancers? That's certainly something that we're interested in exploring and creating basically a super Treg and giving it back to humans. The future direction and vision, certainly not only to train the next generation of physician scientists, but to leverage and integrate the phenotyping of our patients, our preclinical models, multiple disciplines like immunology, vascular epithelial biology, genomics, epigenetics, integrative bioinformatics, and try to come up with personalized medicine in the ICU, which is seriously lacking. Science is a teamwork. I could have not done this without all this work, and I am very thankful to have collaborated with all the people mentioned here. I thank you so much for having me, and I'll take any questions.
Franco, that was elegant and excellent. Thank you so much. I'll begin by asking maybe first a general question, then a specific question. So in general, so the patients that survive ARDS and do better, are they, when we see them in our clinics, is there any benefit to knowing that that's what they had because there are other limitations that we need to look at? Are there long-term sequelae, in other words, of having survived ARDS?
Yeah, this is a tremendous effort by the NIH. There are certainly leaders in the field that are interested in the post-intensive care syndrome. It is not exclusive of ARDS, is well studied in ARDS. There are about 3 phenotypes that you should be looking for. You have patients with neuropsychiatry disorders, patients with PTSD, anxiety, that's one phenotype. The other phenotype is there is true biology in the muscles where the patients become weak. We've had marathon runners that couldn't run a mile after their ICU survivor. And this has been studied over 5 years. They're still weak at 5 years of after an ICU admission. And hence the importance of physical therapy in the ICU and after they leave the hospital. And the other one is, of course, the cognitive impairment these patients have. We've had businessmen that their IQ just was not there to go back to their work. And there's a really true neuronal apoptosis in patients that survive ICU. So it is a true problem that we need to understand.
Specifically the lungs.
Yeah, so it's fascinating. The lungs, that has also been studied. The lungs actually recover over time. After a year, most PFTs are almost back to normal. There's an exception. There are patients that develop true fibrosis. We've seen that with COVID, but most patients, I would say most patients recover their lung function, which is fascinating. It's probably the Tregs.
Okay, I'll take chair privilege and one more question then. So in light of last week's New England Journal article where they were able to molecularly manipulate the CAR T cells by doing adenovirus, could you imagine taking your Treg cells, giving them an adenovirus vector that would then allow them to be not just super T cells, but allow them to even secrete things like interferon locally in the lung that would then even markedly improve outcomes?
Yeah, that's a great question. That is definitely on the horizon. I've been in contact with companies that can almost provide a CAR Treg and customize that Treg to target specific organs. For example, the lung might need different things than the gut. Or if you have inflammatory bowel disease, your gut might need IL-10, for example. Your lungs might need TGF-beta or amphoregulin and other things. So you can customize that. You can do that with lentivirus. You can do that with drugs that make the Tregs super Tregs. And so I am very excited about that avenue in our research, and we are certainly going to help contribute to this.
Good. Dr. Holt had a question. Hold on a second.
Sort of a follow-up to Dr. Weiss's question. So Treg-mediated immunosuppression is often thought to be antigen-specific. And so I was curious if you guys have identified antigens within the lung, especially at ARDS, that you might actually be able to target in a CAR T-like mimicry.
Yeah, that's a great question. I'm going to disclose I'm an immunology in training. I need to get more sophisticated. My Tregs are polyclonal. They're not antigen specific. That does not mean that there's no antigen memory Tregs. Actually, there's a group that published that the outcomes in COVID ARDS were actually more mediated by your number of memory Tregs towards COVID and not necessarily your polyclonal Tregs. Your question is spot on. I think we all know a memory T cell is going to be a much more sniper than a naive Treg. So I don't know the answer about there are certain antigens, but I think you are on the right track thinking that is certainly something that needs to be explored.
Dr. Punjabi?
So two things to say. First, a comment and then a question. There's an obituary written in the journal Chest about a guy named Larry Wood that most people don't know about. The obituary is written by Jesse Hall, who was an ex-chief of pulmonary and section chief of pulmonary at University of Chicago. And I didn't know this either, and I was a medical student at Chicago. What Jesse wrote in the obituary is that Larry Wood was the first one to describe the following comments. When you have acute lung injury or ARDS, do the following. Keep the volume down and don't stretch too much. Those were his teaching on rounds, believe it or not. And I did
Every day, I can
day.
assure you.
That's right. And it's interesting. It's
Spot on.
I trained with him for 6 months as a medical student. I didn't appreciate that. And it was until Jesse Hall's obituary in Chest a few years ago, I said, oh my God, this is the guy that really talked about stretch or overstretching. So just a historical comment. Now, talking about stretch, here's something interesting, Franco. The world of sleep stretches the lungs with CPAP. We thought it was benign. Now there's some data coming out of New York that says even CPAP used for sleep apnea, when overdone, is bad from a standpoint of inflammatory burden. So you're constantly—
repeat that again. CPAP is
C-
bad?
Yeah, well, I didn't say CPAP. Whoa, don't.
No, I didn't hear your last comment.
Yeah, if you overstretch it, if you overstretch the normal person sleeping in, for unrelated disease without acute lung injury, and you said that even in the normal lung, you can overstretch it. And I think this data from New York is very interesting, very preliminary, that if you look at the burden of inflammation, you can actually increase it with just CPAP pressure if too much. Now the question is, what is too much? Where do you draw that line with regards to stretch or overstretching the lung? So I'm just saying that this concept of barotrauma is lowering its threshold further and further down, just like blood pressure and glucoses.
Yeah, I think there is, we target a plateau pressure, which is our surrogate of alveolar pressure of less than 30. But to be honest, there's some data by actually our current MICU director, Dave Hager, that perhaps lowering even further leads to improved mortality. So we go 30, but I think if you have room in the tidal volume and dropping the tidal volume and permissive hypocapnia, I would say target lower. If there's no consequences, I think we should be targeting the lowest possible plateau pressure. And this is where a little bit of the driving pressure concept comes and how you set up your PEEP. But I would say we should not be satisfied with 30. It should be lower.
So the question now is, what is this polyclonal Treg doing in lung injury recovery? What is the exact thing it's doing? It says, hey,
So
start getting, stop the
Right.
inflammation. What is really going on downstream? And I know you didn't have time, but
no, it's fascinating. I think the Tregs are agnostic. They sense inflammation. They migrate to the injured site, and they're polyfunctional. What does that mean? They're not a one-trick pony. They can sense the environment. They can interact with other cells, and they have a armamentarium to control different cells. They can make different mediators that promote repair. I think they're doing some heavy lifting by reprogramming macrophages, where it's much more abundant cell in the lung. Is that right? So I think I can't tell you exactly which one they're using, which one of those mechanisms is a priority, but I think they have the ability to do all of the above, and that's why they're shining. Now, answering the other audience question about memory, I think we're in diapers, all right? We use naive Tregs. We have not modified them. They're not memory. I think we have room to create a super Treg. Much more to be done.
Thank you.
I have a question getting back to your clinical study with Tregs. What is your conclusion from your findings? Is your conclusion that Tregs only work in mild ARDS, or is it that Tregs are actually toxic?
It's two parts to answer your question. I think our trials enroll very severe patients. They're all in multi-organ failure. Now, our low dose Treg showed the survival benefit. Our high dose Treg didn't. It doesn't escape to me that it's possible the randomization, it's not possible. The randomization show that they were sicker, but it is also possible that too much is not beneficial. What if some of those cells turn into pathogenic T cells? I don't know the answer to that, right? That can happen. That's been shown in animals. So I can't tell you that, but I sure tell you that if we run a larger trial, we're definitely not using the 300 million dose. We're going to stick with 100 million. So too much of everything is not necessarily better. What I mentioned is if we looked at the analysis is if we gave those cells within 48 hours of your enrollment, those patients had a higher probability of surviving. If we gave them later, they didn't. So I think there's going to be a critical point where the timing is very important. What I was trying to say is perhaps we can give the cells earlier. We had patients on high flow for 10 days or 5 days before they got intubated. Why are we not enrolling there? Well, we decided to enroll the sickest, but that doesn't mean that's the best strategy. Well, I think this trial will inform us. It's given us green light to proceed. And it's also given us how we step back and say, can we make this trial better? Can we target a little earlier?
Thank you, Dr. Alessio. We look forward to your popping your tent up on 14th Avenue in the very near future, and we welcome you here. And I remind everyone to pay attention to the chat, those of you that are online to get the link for the CME and MOC, and those of you that are here in person can get it outside by taking a picture. Thank you, everybody, for attending today's Grand Rounds, and we'll see you next week.
Thank you.